Right now, somewhere in an emergency room, a heart monitor is showing a perfectly normal heartbeat, while the person underneath it is having a heart attack. Not a glitch, not a delay, a normal reading, in real time during an actual heart attack. If you assumed doctors diagnose a heart attack by looking at a screen and seeing something dramatic happen, a flat line, a jagged spike, an alarm going off, that's not how it works. Most of the time, the first test they run can miss it completely. So if you've ever wondered what a hospital is actually checking for in those first few minutes, because one day it might be you in that bed, or someone standing next to you deciding whether to call an ambulance, you need the next 10 minutes, because the actual diagnosis has almost nothing to do with what you'd expect. Here's the situation playing out in emergency rooms every single day. Someone walks in or gets wheeled in with chest pain. It's one of the most common reasons people show up at an ER at all. And it's also one of the hardest things for a doctor to get right in the first hour, because chest pain doesn't come with a label. It could be a heart attack, it could be acid reflux, a pulled muscle, a panic attack, or nothing at all. And the doctor standing at that bedside has to figure out which one it is, fast, because if it is a heart attack, every minute of delay costs heart muscle that doesn't come back. Here's the part most people get wrong. They assume the doctor is mainly listening to the patient, asking where it hurts, how bad it is, whether it feels like pressure or sharp pain, and making the call from that conversation. That conversation happens, but it's almost the least important part of the process. What actually decides whether you're having a heart attack is a system, a sequence of tests running in the background, built specifically because doctors learned, the hard way, that they cannot trust the story alone. That system is what we're about to walk through. And once you see how it actually works, you'll understand why some of the most dangerous heart attacks in medical history were the ones that looked on paper the least dangerous. The moment someone with chest pain walks through the ER doors, a clock starts, and most patients never know it exists. Guidelines require an ECG, an electrocardiogram, within 10 minutes of arrival. Not 10 minutes after triage, 10 minutes after the door. The ECG reads the heart's electrical activity through sensors on the chest, and it's genuinely powerful. It can catch a STEMI, the most severe type of heart attack, where an artery is fully blocked in seconds. If it shows a specific pattern called ST elevation, the patient is often rushed straight to a catheter lab before anything else is even discussed. That's the version of diagnosing a heart attack most people picture. A machine, a dramatic spike, an immediate answer. But here's the problem nobody puts on the poster in the waiting room. Most heart attacks don't show up that clearly. And in the real world, most patients don't even get that ECG within the 10-minute window. Studies have found it happens closer to 1 in 3, sometimes less, which means for a huge number of people walking in with a real heart attack, the first test either comes late or comes back looking completely unremarkable. So what happens when the ECG says nothing's wrong and the doctor still isn't sure? That's where the second test comes in, and it's the one almost nobody outside medicine has heard of: high-sensitivity troponin. Troponin is a protein that leaks into the bloodstream only when heart muscle is actually dying. It's not present in any meaningful amount otherwise. So instead of asking, "Does this look like a heart attack?" this test asks a more brutal question. Is heart tissue dying right now, measurably in your blood? The catch is timing. Troponin doesn't spike instantly. It takes roughly 2 to 3 hours to rise after damage starts. So doctors draw blood the moment you arrive, then again an hour or 3 hours later, depending on the assay their hospital uses. And they're not just reading the number, they're watching whether it's climbing. A flat, low number across 2 draws is one of the strongest signals in medicine that you're not having a heart attack. A rising number, even a small one, can mean the opposite. 2 tests, one reads electricity, one reads dying tissue in the blood. Most people assume that combination is the whole story. It isn't. There's a much bigger reason this entire 2-test system had to be built in the first place, and it has almost nothing to do with machines. Here's what actually forced emergency medicine to stop trusting the conversation at the bedside. Doctors used to lean heavily on how a patient described their pain: crushing chest pressure, pain radiating down the left arm, the textbook picture. The problem is, That textbook picture is built largely on how heart attacks tend to present in one demographic, and a huge number of real heart attacks simply don't look like that. A landmark study of over 1 million heart attack patients found that 42% of women having a heart attack presented without chest pain at all, compared to about 31% of men. Instead, unusual fatigue, nausea, jaw or back pain, or just a vague sense that something is wrong. Older adults and people with diabetes show a similar pattern. Absence of chest pain shows up more often in exactly these groups. Sometimes because nerve changes from diabetes itself can mute the warning signal, which means the ECG plus troponin system isn't just a backup plan for unclear symptoms. It exists because your own description of what you're feeling, the thing you'd assume is the most important piece of evidence, is one of the least reliable signals in the room. The system was built to overrule you, on purpose, because trusting the story alone was getting people sent home while they were actively dying. So if the doctor can't fully trust the ECG alone, can't fully trust the blood test alone, and can't fully trust what you're telling them, how does anyone actually make the call? They run all of it through a single scoring system called the heart score, first developed and validated by a team of Dutch cardiologists. History, ECG, age, risk factors, and troponin, each scored on a simple point scale. Add them up, and the total sorts you into a risk category: low, moderate, or high. A low score, paired with a clean troponin result, is often enough to send someone home the same day, one of the safest, most well-validated calls in emergency medicine. A high score does the opposite. It fast-tracks a patient toward the cardiac catheter lab, sometimes within the hour. That number gets calculated quietly for almost everyone who walks in with chest pain. And most patients leave the hospital never knowing a score like that existed, let alone that it just decided the next several hours of their life. Once that number lands on the high-risk side, a different clock starts. The moment a STEMI is confirmed, hospitals work against a 90-minute target, door to balloon, meaning from arrival to the moment a blocked artery is physically reopened. Every piece we just walked through, the 10-minute ECG rule, the troponin draws timed almost to the minute, the heart score doing math in the background, exists to feed that single number, 90 minutes, because heart muscle that goes without blood for too long doesn't come back, no matter what happens afterward. So the entire diagnosis isn't really one test, or one moment, or one doctor making a judgment call. It's a race against a countdown that starts the second you walk through the door, one that most people in that waiting room have no idea is already running. So here's what actually determines whether a heart attack gets caught in time. Not a single dramatic test, but 3 separate systems: electrical, chemical, and statistical, each built to catch what the other 2 might miss, all constructed around one uncomfortable discovery: that trusting a patient's own account of their pain was, for decades, quietly killing people whose heart attacks simply didn't look the way medicine expected them to. But here's the part that doesn't get said enough. All of it. The 10-minute rule, the troponin curve, the heart score, the 90-minute countdown, only starts once someone is already standing inside the hospital. None of it does anything for the person sitting at home an hour earlier, deciding their jaw pain is probably nothing, or that the fatigue is just a bad week, and choosing not to go in at all. The system inside the hospital was built to stop doubting the human being in front of it. The one weak point left is the decision made before anyone ever gets that far.